Good afternoon, everyone. Welcome to the Dr. Santosh Kumar Memorial Oration. I would like to call our Honorable Secretary, Dr. Debashish Das, to come to the stage to take over as the moderator of this session.
May I welcome the chairperson, Dr. Arup Chakraborty, and my co-chairperson, Dr. Amitav Biswa, to please be on the dais.
As our dignitaries join us on the dais, I'd like to introduce this oration. So this is in the name of Dr. Santosh Kumar Das, who led a life of inspiration. He was born to the renowned Dr. Radhakrishna Das and Srimati Nolini Bala Das in 1934. He used to walk 8 kilometers every day each way to attend school. He was in Bongobashi College after matriculation for his ISc, and he completed his MBBS from NRS Medical College. He was an excellent sportsman, especially in athletics, soccer, and table tennis. He joined the Association for Prevention of Blindness under the West Bengal government to eradicate blindness in the rural areas after his house staffship. In his early life, for the next 5 years, he continuously labored all over rural West Bengal to treat the poor for various eye conditions. The Prime Minister of India, Srimati Indira Gandhi, felicitated his work and sent him a letter of appreciation, mentioning his dedication and idealism. He married Srimati Pushparani Das in 1962. She was a constant source of encouragement and support throughout his personal and professional life. Dr. Das founded the eye hospital Radhakrishna Shebayaton at Mondir Bazaar to treat the underprivileged. This hospital was named after his father. This hospital is still being run by Dr. S.K. Das's son, Dr. Debashish Das, who is with me on the dais, who also runs the Eye Foundation Center. He was very passionate. He was the organizing secretary of the 3rd annual conference of the West Bengal Ophthalmological Society at Mondir Bazaar in 1969. While working, he then studied to complete his DOMS and MS in eye surgery from Calcutta University. He continued to do free eye camps in West Bengal and Orissa. He founded the Florid Nursing Home in 1987, naming it after his wife. The Florid Nursing Home has now expanded to become the Eye Foundation and Research Center, Calcutta Orthopedic Center, and the Children's Clinic run by his sons and daughters-in-law. He was elected president of the Indian IOL and Refractive Society in 1994 and was elected president of our very own society, OSWB, in 2000-2001. He received a gold medal for the best paper at Chennai International IOL Conference in 2003. He was an inspiration. Dr. Santosh Kumar Das inspired everyone around him, both on a personal and professional level. He served the community at large as a medical practitioner and as an established member of our society. And he taught everyone around him how to live and prosper, and this is why we still remember him. Thank you.
We take great pleasure to invite Dr. N. Venkatesh Prajna for the oration today, Eminence versus Evidence. I'd like to introduce Dr. Prajna before we invite him on the dais. Dr. N. Venkatesh Prajna is the Chief Cornea and the Refractive Surgery Services. He is the Director, Residency Training at Aravind Eye Care System, as well as the Secretary, Finances, Aravind Eye Care System. Dr. Prajna did his MBBS from Madurai Medical College in 1989, and thereafter DO from the Tamil Nadu Dr. MGR Medical University in 1991. His DNB in 1993, and thereafter did his fellowship in the Cornea and External Diseases Aravind Eye Hospital in 1997. He was conferred with the FRCO Opt from the Royal College of Ophthalmologists, UK in 2003. Dr. Pragya has been working in Arvind as a consultant in the Department of the Cornea Services for over 2 decades. He is the head of the department over the last 15 years and is instrumental in developing the department to be one of the largest cornea facilities in India, seeing numerous infectious keratitis patients. Apart from his clinical commitments, Dr. Pragya has a special interest in the basic and clinical research pertaining to corneal infections. He has over 200 peer-reviewed publications in the leading international and national ophthalmology journals and is a peer reviewer for many prestigious journals. Dr. Pragya is an academic director of Arvind Eye Care System and a professor of ophthalmology and recognized PhD guide under TN Dr. Tamil Nadu Dr. MGR Medical University since 2003. He also serves in the advisory board of one of the most prestigious and respected international journal, namely JAMA Ophthalmology. He has been selected as one of the top 2% of the global researchers in ophthalmology for the prestigious Stanford University, USA. In 2024, he was awarded the Saichi Mishima Award by the Asia Cornea Society at Jakarta for his recognition of the lifelong contribution and achievement in the field of corneal research in Asia. We all have read this book in our post-graduation days, the Payments Volume 1 and the Volume 2. And Dr. Pragya is the only one who has been editor-in-chief of this prestigious book. In his preface to the second edition, he wrote, "It is very rare to get an opportunity to become the editor-in-chief of the same book that one studied during the residency years. I consider myself immensely fortunate to have got this chance to edit the book, which was my guiding force during my post-graduation career." This is the picture from the same book where we can see Dr. Pragya amongst all the stalwarts in ophthalmology from the Arvind Eye Care Systems. With this backdrop, may I invite Dr. Pragya, Dr. N. Venkatesh Prajna, to please come up on the dais, sir. May I request Dr. Amitava Biswas to present the Oration medal and the shawl to Dr. Venkatesh Prajna. May I please request, sir, to please go ahead with the oration.
At the outset, I would like to thank Dr. Rupak and the entire team of the Ophthalmological Society of West Bengal for this very prestigious invitation. In fact, Dr. Rupak asked me to come and speak last year itself, but I had already had an international commitment, and so I could not come, and I feel it's indeed my fortune that you still asked me this year, and I'm very, very happy and honored to come here. So what I thought was in this next 20 minutes, I'll be sharing about my personal experiences in conducting clinical trials, which are now being used across the world. It all emanated from a small town of Madurai. Before that, I would like to pay my tributes again to Dr. S.K. Das for a life of inspiration, a life spent in community ophthalmology. I'm also very happy to know that this hospital is still being run today, continues to run and continues to flourish under Dr. Debashish. So, as rightly pointed out by Madam, he was also president of the Ophthalmological Society of the same organization in which I'm lecturing today. So while I pay my tributes to him before I start my lecture, it's often told that lightning never strikes the same place twice. The chance of a lightning hit is 1 in 15,300. The chance of a second hit is 1 in 9 million. And that is why they make a statement that lightning never strikes the same place twice. This is a true story of Major Walter Summerford, who first had a lightning strike in 1918 in Belgium, and then he retired as an army officer, went and settled in Canada, had a second strike in 1924 in Canada. Lightning did not allow him again. 1930 he was struck for the third time. And that is what chance is all about, and that is what the difficulty of conducting any clinical trials and interpreting the results become all that more difficult to interpret. Now the thing is, Mr. Summerford at that time in 1932 died after all these attacks. He survived all the attacks and then he died in 1932 and he was buried in Mountain View Cemetery in Vancouver, Canada. And in 1936, lightning struck that cemetery once more, breaking that cemetery stone. So that is the range at which statistics can be employed to sort of find out, what is the chance of this happening. So I'll come back to this person later in my talk, but just register this in your mind while you hear this. So I'm going to talk about 3 important things here, and all 3 were the direct clinical trials in which I was involved primarily. And the last trial which I'm going to talk to you, it has been accepted in JAMA Ophthalmology. It's going to be published 2 months later, but you're going to hear it for the first time today in India. So the first thing is, in my experience, can cornea specialists predict the causative organisms based on clinical signs? If you ask me, I thought I would do well. I've been seeing cornea for 25 years, and I thought if you ask me this question, probably I would say, yes, I can diagnose. But not all corneal ulcers present like this. If it presents like this, you're very sure that it's feathery edges, most probably it's a fungal ulcer. Or if it presents like this with all these pigmentations, you're also reasonably confident that it is caused by pigmented fungal ulcers. But most of the ulcers present like this. That's the problem. They don't read the textbooks, so they present in the way they want to present, and it's up to us to interpret whether it's caused by bacteria or fungi. So you thought acanthamoeba, the traditional teaching causes round ulcers, but here I'm giving you 4 different round ulcers caused by 4 different organisms, each causing a typical round ulcers. And for example, this small ulcer, according to me, this is a very, very small ulcer, but from that ulcer, we had 3 organisms, fungus, gram-positive cocci, and gram-positive bacilli taken out of it. So I come back to my first question. By looking alone, can we detect whether it's caused by bacteria or fungi? So we did a study in 2012, which we published in IOVS at that point of time, and where we showed 15 cornea specialists, we just showed them pictures and asked them whether this is caused by bacteria or fungi. And then we showed them 80 photographs. You know what? They were able to detect, they were right 66% of time, just above chance. And these were not residents. These were established cornea consultants across the globe. So this is the thing, of eminence. You should be very careful about the senior consultants or even a person who's been in this department for a long period of time. Without evidence, it is rather an impossible task. So we thought, okay, let us do one more. And we said 2022 we did it, and then this got published in the prestigious Journal of Ophthalmology, where we now had close to around so many people across, we had 33 consultants in temperate climates, mostly in the US, but also in India and in other places of Africa. And what happened was anything above 0.85 is good. The expert performance was between 0.39 to 0.81, meaning they were right only 39% of the time. The range came from 39 to 81%, but these are established cornea specialists. But what was very nice is you can see the blue line is Indian ophthalmologists. Since in India we see both bacterial and fungal, our clinicians were better than the US clinicians in detecting without microscopy whether the ulcers are caused by bacteria or fungi. So what it essentially means is, as clinicians, as established clinicians, as cornea specialists, we are still not able to do it without the aid of microbiology. So what we did was, whether we developed an AI tool, we worked with our colleagues in UI, and when we published this in Ophthalmology Science 2022, where we sort of looked at 5 AI models, and then we concluded that the AI model was having an AUC of 0.86. The AI model was much, much, much better than clinicians across the globe. So this is the important statement. I was there before the talk. I am very much convinced that the whole part of diagnosis will go out of our hand very, very soon. The diagnostic part, it will not be with a tool, it will be in an iPhone or a Samsung phone. It will not be there in a very sophisticated instrument, because the algorithms which is going on in this field is phenomenal, and then it is very meticulous, and then anything which is being taught repeatedly is going to make a much more difference than clinicians. So that was the first revelation with regard to the diagnosis. The second part, the MUT study, which I was again the PI, from 2000 to 2005 was a very big thing in fungal keratitis, because natamycin was discovered in the 1960s. Until today, that remains as the drug of choice. And 2000, when voriconazole came, it came with all these publications, very good results. You see all these things resolve. And then was the only drug to which 100% of fungal isolate was getting benefited. So we were all very happy. Okay, a wonder drug has come, and hopefully all our problems with fungal keratitis will get resolved. In 2008, a meta-analysis paper was written in the BJO, where they were saying that it is very safe and very effective against a whole lot of fungal pathogens. And then the Cornea Society, which is the apex society for all the cornea specialists, they did a survey, and then they found out that 80% of the ophthalmologists would prefer voriconazole if a choice was given to them whether voriconazole or natamycin can be used. So that was the whole thing which was happening between 2000 and 2008. So at that point of time, I was actually doing a NIH-sponsored clinical trial with the University of California, San Francisco. When I was starting, I think I was wasting my time. Why are we comparing a drug which was discovered in 1965 and comparing it with a wonder drug which was actually coming out in 2001, 2002? And what it came out from this study, and which we published in 2013, was the drug which was discovered in 1965 was still better than the drug which was discovered in 2002. And natamycin was much better. I think one of the important things which came out of this study, which has got ramifications beyond ophthalmology, was for the first time we demonstrated that different fungi respond to different antifungal drugs. Fusarium responds much better to natamycin, while Aspergillus responds equally well to voriconazole and natamycin, in fact, slightly better for voriconazole. So I think that is what is the most important thing from this study, which was published in 2013. It raked up a huge controversy, but it's very important in our country because in the southern part of India, it's all Fusarium. In the northern part of India and in the eastern part of India, it's Aspergillus. So we really need to know that there is a differential response to treatment, and we need to understand from where this organism is being isolated. Now, what happened between 2002 to 2009? We tested in our laboratory, we found out that voriconazole was a wonder drug. What really happened was the fungi became resistant to voriconazole because voriconazole was being used right, left and center in the field of agriculture. Natamycin, if you know, is not systemically used. It is not used in agriculture. So that is why from 1965 it still retains its potency. So that is the thing at which you need to understand when evidences are being present to this. What was also very interesting is there have been list of randomized controlled trials, and just see the last line, no significant difference till the mud study came into the picture, where for the first time we showed that there is a significant difference, that one drug is better than others. Now this was a very interesting paper from L.V. Prasad Eye Institute. They said, when the mud study results came, it was very unusual, so we really wanted to see whether that result was right or wrong. That was a very unusual type of a paper. So it was called reappraisal, completely different institution. And then they also concluded, when compared with voriconazole, natamycin was more effective. Now this is the power of research. When your study is being when you give a result of your study, it is being independently reviewed by another group of people, and then see, we didn't believe that results were true, but we let us look at it, and then this was what was found out. And a very proud moment for us was this thing when the Moorfields Eye Hospital changed their treatment management guidelines based out of a result from Madurai. So that is also a thing which we could influence treatment. So I told you about that expert opinion, which was done in 2007 by the Cornea Society. 80% preferred voriconazole, and the Cornea Society repeated this opinion poll 2017 after all our publications were over. 70% of the US ophthalmologists prefer natamycin. So that is the power of evidence. When you are able to give evidence, when you are able to do a study in a rigorous manner, you are able to influence the thought process across the world, irrespective of whether you come from India or China or any other place. So I finished two of my things, and I told you about this third part. The third part, as I said, this is accepted in JAMA Ophthalmology. This is going to be published 3 months from now, but I'm just sharing the results from this study. So as you know, a large interest is going on with cross-linking being used for infectious keratitis. And these are all studies which just show that cross-linking really works for infectious keratitis. Just to give you a picture. But this was one study which I was very interested in. 2012, it said bacterial keratitis, even if you don't use antibiotics, if you just cross-link, it will work. And this got published in One Graphis things. So this is where things became interesting. I said, oh, it must be really a wonderful thing then. Why don't we try this? And then we did the steroid corneal ulcer trial. We have expanded it. We did it on 280 patients. As I said, we just finished this trial 6 months back. It's on our publication. The first group had Moxi plus placebo. We wanted to see whether addition of steroids work. So the second part was Moxi and steroid, but sham, meaning no cross-linking. And the third group was Moxi, steroids, and cross-linking. No significant difference. No significant difference when you use cross-linking. And in fact, if you use cross-linking, there is an increase in the scar size, increase in the infiltrate. And so with Dresden protocol, and I want to study whenever younger doctors study the conclusion part, you always have to see the methodology. What was the methodology which was employed to do this clinical trial? And so we're using Dresden protocol. There doesn't seem to be any benefit in the bacterial keratitis, even though the perforation rate when you use steroids and cross-linking is slightly less. But the only problem is, for this study, we had 280 patients. But if I had to design a study to just estimate the difference based on perforations, then I would require 3,000 to 3,200 patients. This is the problem with doing real world studies. So this is something of interest to me, which says that perforation is less, but slightly of concern to me that the vision is slightly poor in this. So at this point of time, no significant benefit in bacterial keratitis. For fungal keratitis, I may come up with a different result because I'm trying to use rose Bengal and green light in treating that, and I find there is some effect to it. I'm going to present the results in the World Cornea Conference in DC in March, because I'll be getting the results in January of next year. So here at this point of time, as I said, no benefit in using cross-linking for bacterial keratitis. Now I alluded to this, a person sitting in a sculpture sitting in a river, in a flowing river, reading a book. But actually this is not one person, it's just combination of stones. If you really see, these are just stones arranged in a random order. But if you see it in one angle, it just looks like as if there's one person sitting there reading this. So this is how you should be really careful when you're interpreting any result as a whole. So this, I'm sure many of you, this is much before artificial intelligence was employed. Much before. You know this famous Zidane thing. But what you can do is you can actually make it look as you want it to be looked. You want it to be look like this style, or you want to do it like this, you can still make it happen. This was much before the world of artificial intelligence. So this is something which you need to be very cautious when you're interpreting data. So I do hope this talk gave you an idea that, if somebody eminent, we give them all that respect. I mean, I'm also in that range now. So you can give me all the respect. As I tell people, you are standing in front of me, so I know that you are alive, but all the other things you have to substantiate with data. Otherwise, you'll just get fooled around by all these things. So evidence is always much more important than eminence. I would once again like to pay my respects and regards. This was very interesting. He taught everyone around him how to live and prosper. A person who takes things and allows the other persons to live and prosper. This was something which caught my eyes. I pay my tribute once more to Dr. Santosh Kumar Das, and I would like to thank each and every member of the esteemed society of West Bengal who have given me this opportunity to come all the way from Madurai to be in your midst. I recently delivered the oration at the All India Conference, the G.N. Rao Oration Conference in Calcutta. So Calcutta is something special to me. You have given 2 medals to me in 6 months. So I'm really thankful for each one of you. And if you would have seen, all of us at Aravind, we like putting this slide. Dr. Venkatesh was also putting like this. So the last line is more important for us. Everybody can be intelligent and capable, but doesn't mean anything as long as you are able to make a difference. For me, it was a very proud moment that we could influence the whole treatment paradigm of the UK. And it's very important for you to understand is at that point of time, UK was manufacturing voriconazole. UK had to import natamycin from Canada. But when our study, which came out of India, came in the press, immediately they changed the treatment protocol, and for 1 year the NHS imported natamycin from Canada based on a good study out of India. So that is how much influential you can become when you are able to conduct a study which is right, which is relevant, which is reproducible, and also which is also be useful for the society at large. Thank you very much.
Thank you so much, sir, for your insightful oration. May I request my audience to please give him a standing ovation. May I request Dr. Amitava Biswas to please present him with an oration plaque. May I request Dr. Rupak Kanti Biswas? Dr. Rupak is not here. May I request Dr. Tulika Ghoshal to please present Dr. Pragya with a memento. Please take a group photograph.